The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. This is Deborah Curdy, and thanks for joining us for our rebroadcast of our September 29th webinar, Antimicrobial Stewardship Actions and Interventions in the Nursing Home Setting, with Dolly Green from Diagnostic Labs and Dr. Erin Epson from CDPH. If you have any questions, please feel free to ask them in the question box on the right-hand side. So let's get started. I'm going to turn this over to Dr. Erin Epson. Good afternoon, Dr. Epson.
Thank you, Deborah, and thank you to others at CAF and QCHF for producing this webinar series with us. Thank you all for joining us today, and many thanks to our presenter, Dolly Green, for providing this webinar again. Can you advance the slide, Deborah? I just wanted to make a quick announcement. If you weren't able to attend earlier sessions, or if you'd like to share information from our sessions with colleagues, we have webinar recordings as well as several implementation examples now available for free on our program's website, and you can see the URL at the bottom of the slide here. So the implementation examples include policy and procedure document and an ASP notification letter to physicians, as well as several other tools for suspected infection assessment, as well as communication tools. And these are available for your review and adaptation. We're very grateful to their contributors, and we would also welcome additional contributions, so feel free to get in touch with me if you have something to share. And also consider bookmarking this website as we'll continue to post sessions and add to the collection of examples as we go. Next slide. So today, as was mentioned, we are rebroadcasting the fourth session in this six-part series, Stewardship Actions and Interventions in the Nursing Home, Optimizing Diagnostic Testing and the Role of the Consultant Laboratory. Next slide. So now I'm pleased to introduce the presenter for this session, which is Dolly Green, who's Director of Clinical Services of Infection Prevention and Control with Diagnostic Laboratories and Radiology. Now, Dolly is a registered nurse, board certified in infection control. Dolly has worked in the field of infection control for over 25 years and has been involved in long-term care for more than 30 years. She's spoken at conferences and conventions for various organizations throughout the United States, and we are grateful that she has agreed to provide this webinar for us. So I'll turn over the webinar to you, Dolly. Thank you.
Okay. Very good. Good afternoon, everybody, and thank you, Dr. Epson, and to QAF for inviting me to be part of this very important webinar series. Even rebroadcasting is a pleasure. Okay, so you know my topic. Oops, what happened to the Deborah? Already I'm in trouble.
Okay.
Advancing. How do you just, okay. All right. My objectives for this session are, at the conclusion of this hour, I hope you'll all be able to describe the unique challenges that nursing homes may have when beginning an antibiotic stewardship program. I'm pretty sure you're pretty much aware of all of these challenges. I also hope you'll understand the significance of appropriate use of lab testing. And this is an important element in getting your stewardship program up and running. And ultimately, I hope you'll be able to explain the role of the laboratory in providing you data to support your stewardship efforts and plans. Okay. Nope, I lost it again. Okay, wait.
Okay.
I think you're going to advance, right?
Yeah, just say next.
Okay, but where are you? Oh, here it is. Okay. All right. So as we all know and might expect, there will be a number of challenges we face in implementing a stewardship program. We realize that the residents we care for are aging, and along with that comes many changes that they're going to be experiencing. We realize also there may be exposures to infectious pathogens, whether the residents are admitted with these agents or perhaps they're developing them from within the facility. Our residents are more debilitated and come to us with many comorbidities. With more acute illness, we tend to see more invasive devices. like your IVs, your PICC lines, and your G-tubes. I can't remember years and years ago, these types of patients were not seen in our long-term care setting. With more acute illness, we tend to see more of these invasive devices. We also are faced with pressures from families to order lab tests, which ultimately can lead to antibiotics that may not be necessary. Years ago, again, I have to refer to how families used to come to us and just let us know that they think something's going on with their loved one. You know, mom's not looking so good. Can you come and take a look? Now everybody's a Google doctor, and everybody has Googled the situation, and they come to you with a complete treatment plan. Mom's got a UTI, mom needs a urine specimen collected, send it on to the lab, and when that result comes in, I want you to start her on Cipro. This is all coming from families. So this in of itself is a big challenge. When we do cultures without clinical justification for these tests, we end up discovering colonizations of skin, urine, oropharynx. Many times cultures are positive without the absence of infection. Nursing homes are also greatly challenged with having limited resources, as we can all attest to. Next slide. Deborah? There we go. Okay. In addition, physicians are not always available to us on the premises and often don't actually even see the patient before ordering the antibiotics. Just last week, I attended ID Week in New Orleans, and I was in the audience when Dr. Namali Stone, and I know most of you are familiar with Dr. Stone, especially since she was the lead author of the revised McGear's criteria. And what she said was 67% of antibiotics ordered in nursing homes are done over the phone. So you can well imagine this is a great challenge. I think this may be changing, this next issue that I'm about to mention, but in the past, doctors have had reservations about the assessment skills performed by nursing staff in nursing homes. And I think that has improved. I think the nurses are way more skillful than they ever have been. So I gotta get rid of that. We know that diagnostic services are not on the premises of nursing homes. You know, they're not a constant presence there. So turnaround time may not be as rapid as you might see in an acute care setting. It's also very challenging when residents aren't able to communicate how they feel or any symptoms they may be experiencing. We also realize that the elderly and frail may have atypical presentation of infection. As an example, fever may not always be present as one of the first signs of infection. So this makes it really difficult to diagnose infection as well. Next slide. Okay. Additionally, as we all know, the attending physician may not always be the one receiving the initial change of condition report. It often may be an on-call physician. There continues to be pressure from families to order labs, as I mentioned before. They don't quite understand how ordering tests can lead to ordering unnecessary antibiotics. They don't see that connection. Many family members are old school and believe that the doctor knows exactly what to do no matter what reports he may see, and so the doctor usually knows best. So they don't understand that that sometimes clouds the judgment, if I might say that, or at least complicates the decision-making process when there's a lab not based on a clinical foundation. Finally, the concerns of litigation. I've had many conversations with physicians over the years about antibiotic stewardship, and I am really surprised, and I can't even tell you how many of them have expressed this concern. I've been told that they understand the concept of antibiotic stewardship, but even with that knowledge, they're fearful of getting sued. So they're going to order the antibiotic anyway, even without localizing specific symptoms. Next slide. So we know we've got a number of challenges, but our nurses also have their own challenges and struggles when it comes to infection control and stewardship efforts. We know that our nurse, who is usually designated the infection preventionist, may be wearing many different hats. So it's hard as far as time, constraints for her to really do the job as it was meant to be done. Turnover of staff is high. Just when an IP feels that she or he has trained their staff on best practices, they have a healthcare worker or a number of them quit and move on. So requiring a whole new orientation to the practices. Even the position of the IP herself has turnover. The demands of this job are so great now. The nurses give up due to lack of time and resources. They feel frustrated that they cannot do all that's expected of them. And now with the new CMS requirements of participation that were just finalized and came out October the 4th, it's actually made it very specific that nurses who do infection prevention and control in the nursing home setting, that it now should actually be 1 or 2 people who gets assigned to this one job, and that formalized training is necessary. And I can tell you, even though those rules and regs are due to go into effect in a phasing in and may not be effective for another year or so, that surveyors are already asking our IPs if they've received any training, and they don't leave it just there. They want to know that they want to see the proof that you've had that training. So training for IP in nursing homes is not so easily available, even though that training is mandated now. And the time they need to get out of their facilities is not always given to them as well. So I have, so yes. All right, next slide, please. So where are we going to start? Next slide. A good starting place would be, next slide, yeah, thank you. A good starting place is right here. The CDC has developed core elements for antibiotic stewardship, specifically in nursing homes. It's similar to the ones for other care settings, but we have our own actual core elements. And you can access this very helpful document on the CDC website that's listed here at the bottom of this slide. It's cdc.gov/long-term-care/antibiotic-stewardship.html. And I really would encourage you to make sure you have a copy of that, because in the back they have a checklist for you to work with, so that you be sure that you hit on all of these elements. And I also want to add, be sure to personalize it to suit your particular facility and its challenges as you develop your policy. And even with that, as Dr. Epps mentioned, there is an example on the CDPH website, so you don't have to reinvent a wheel. There is already a wheel there. If you just go to the CDPH website, the HAI part of it. Okay, so part of your, as you can see in these core elements, you need to identify champions to lead your stewardship efforts, and they recommend medical director, of course, be part of that team, and a pharmacy consultant. In addition to them, you would also want to include your laboratory representative, because they have data to share. Your infection preventionist is an integral part, because let's face it, in the end, all of this, orchestrating this whole stewardship program will probably be part of the job description or part of the IP's responsibility. And, there, as I've been experiencing some of these programs starting in facilities already, there are still challenges with many of the things that we've said, even when the nurse takes responsibility and tries to engage in conversations with physicians to either discontinue an antibiotic because once the laboratory data is made available, it turns out they don't really have an infection according to the findings and according to the reassessment of the resident. But even with that, it's hard for doctors to accept that guidance or recommendation from a nurse. So I also want to add, considering getting an ID physician who is trained in antibiotic stewardship to somehow work into your stewardship program, because at that point when the nurse is no longer able to help, get the patient's antibiotics discontinued or changed, an ID physician speaking to a peer, his information may be more easily accepted by another physician. Next, you want to choose something to focus your activities on, and something that's easily studied. We all call it low-hanging fruit, and that's something that everybody typically might identify as an issue that gets a lot of antibiotic treatment. As a suggestion, I know when I talk with facilities in person, they all tell me they want to study the urinary tract situation, the events that get treated with antibiotics. So when you do all of these efforts, what you're going to do when you do your tracking and you figure out what you want to focus on, you want to then correlate to outcomes. What are you seeing has impacted, like perhaps development of MDROs or C. diff? With this stewardship program, have you started to see less of those being identified in your building? And of course, one of the other important elements is not to forget to give feedback to your staff and to your providers. And don't forget your residents and families. They, of course, need a lot of education. And I can also add that there's many tools out there on some very good websites. CDC has some wonderful tools about antibiotic use that you can utilize in your education endeavors with your family members. Okay, next slide. So again, where do you begin? You're going to get start out. So to start out to be successful, you may need a lot of support and buy-in from your medical director, administrator, and your director of nurses. There may be times, as I've experienced, where a doctor doesn't take advice very well from a nurse and goes running to the administrator or the DON complaining. So you really want to make sure that you're all on the same page, and so that you can all work together as a team to make physicians and nurse practitioners and physician's assistants understand what it is you're trying to accomplish. You then choose an area to focus, as I said, and create a policy, begin training your nurses on your goals and best practices. So before you start this whole process, you absolutely need to get your nurses, number one, the information about what we are doing and why we're doing it. And number two, what I really think nurses need are the tools to be able to have communications with physicians more than just being so robotic and taking orders. They need to have the words in which to use when they're talking with a physician so that they don't sound like they're challenging orders, because we are not there to challenge the physician by any means. What we need to try is to just ask a lot of questions. So begin training your nurses on your goals and your best practices. And these conversations, you may want to do role playing with them. Another thing, another area to start with is developing a working relationship with your acute care partners. Now this is a really big thing, and it helps you on many levels. Hospital readmissions, infection prevention and control, and stewardship. Getting together with your hospitals can really help bond one another, and also just so that you know who to speak with when you are having some sort of an issue that requires attention perhaps on the part of acute care as well as long-term care. And our public health system, our CDPH has been wonderful in developing a lot of collaboratives throughout the state, a couple on CDI, Clostridium difficile infection, another one on CRE, but there's nothing that says you can't develop your own collaborative with your hospital and their network of facilities. We now know, as we've been told over and over again, that we cannot operate as silos. That era is long gone. All of us need to reach out to other partners, because our residents may stop in many places along their way in the continuum of healthcare. So we want to make sure that everybody is on the same place, and working in concert. Next slide. Okay, so as you develop your program for antibiotic stewardship, you will want to utilize communication tools if you're not already working with like an SBAR, which will help organize your nurses when they need to report their assessments. First of all, it lays out what they actually should be assessing, and what information should be collected when they call to report to the physician. Work with your ASP committee to establish a best practice decision tree for use of diagnostic testing. This will help guide your staff and clinicians when the time for ordering labs would be indicated based on the resident's clinical condition. And I want to emphasize that the clinical condition, meaning the signs that the resident might be manifesting, that is what antibiotics should be based on prescribing when you see that a resident is clinically ill, not just on the basis of a lab report or a x-ray report. So an algorithm for antibiotic use can also be established by your pharmacist in conjunction with your medical team and medical director, and they can use your specific facility antibiogram. And later in this presentation, I have an example of what that might look like. Another thing that you might consider is utilizing an antibiotic timeout, and share this information with your nurses and physicians, the whole concept surrounding what antibiotic timeout actually is. Basically, it's revisiting the need for the antibiotic that may have been prescribed empirically 48 to 72 hours ago. And once more information becomes available, like your labs, the reassessment of your resident's clinical condition should take place, coupled with the new diagnostic data that may be available now. The antibiotic, according to the CDC and according to CDPH and experts, they encourage trying to do the timeout, which means stopping it at that point. Nurses really need to get comfortable with this concept, calling physicians and asking this question. So they really need to be clear about what it is. And one pitfall that I have discovered from facilities really latching on to this idea is be sure you're not trying to monitor your acute care hospitals ordering habits or patterns. So when you get a patient when you get a resident from an acute care hospital, they may have been on an antibiotic, but by the time they come to you, their symptoms may have already abated. So when you look at this resident as a new admit and you see this antibiotic, what I've experienced, some nurses have thought, well, I'm going to call the hospital and do a timeout. This timeout concept is for you to use for your facility. I believe most IPs in long-term care have enough to manage, I'm sure you'll agree with me, and you don't have to take on managing the antibiotic utilization of acute care. So consider whatever is ordered in your facility, that's what you want to be looking at. Okay, next slide. Oh, another one, just one other aspect of, this is another strategy to use, and again, this is something that I heard spoken of a lot in at ID Week, is if you cannot get a doctor to discontinue an antibiotic order, you might consider de-escalation of the antibiotic. So once your sensitivities have come in, check with the doctor to see if he'd like to use a more narrow spectrum antibiotic. And with your antibiogram, you can actually provide him, you're not going to choose what it is, you provide him with that information by reading off from your antibiogram. Okay, so in looking at the appropriateness of the antibiotics ordered and lab tests ordered, you may want to track a variety of things. And this slide, these pearls of an antibiotic stewardship program comes from a program started by Dr. Rika Murthy at Cedars-Sinai. And she allowed me to use this slide to share with you, just to show you the metrics that her program, her enhanced care program, started measuring last year in their network of 8 skilled nursing facilities. So to begin with, when you start to track, you want to take a baseline for these metrics and then record them each month thereafter. So do your baseline, do your education, and then each month figure out how you are hopefully improving on the numbers of cultures ordered, how many are positive. Hopefully you'll have less cultures, and the cultures that are actually done will have more positive, because what I see when I go to facilities, that sometimes more than half of the cultures ordered are negative. So that in of itself can help with cost saving. Also looking at how many of your cultures are suggest colonization or contamination, how many antibiotics are actually ordered in nursing homes, also the number of days of therapy. Doing point prevalence of the antibiotic use is a good thing to do. So how many at any one given time residents how many antibiotics are prescribed, how many are prescribed empirically before they get results. The current trend from what I'm hearing is that if your resident is not manifesting chills and fever and is not really more than, does not appear really seriously ill, perhaps starting nursing measures, watching this resident. Yes, if the doctor orders the UA-CNS, please do it, of course, and then once the information comes in, the data, then you can figure out if an antibiotic is needed. Also looking at how many of the residents that get antibiotics and are being treated with low colony counts, how many meet the McGear's criteria, meaning that if they have actual clinical symptoms, and then as an outcome measure, track how many residents are tested and are positive for C. diff, and you can actually track other MDROs as well. Okay, next slide. So once you have an AS committee with expert ID involvement and, pharmacy and a physician, have them develop a decision tree for when it may be appropriate to order a lab or an x-ray, and then how they want residents to be monitored if if tests are not ordered initially. So there can be a set order of monitoring, taking vital signs however often they want, monitoring fluids, increasing fluids, those types of measures until you actually get your final results. As published in the Canadian Journal of Infectious Disease and Medical Microbiology in 2009, as referenced on this slide, experts have stated, and I'm sure this is not news to any of you, but experts have stated mental confusion alone, all by itself, does not warrant ordering a urine culture. So for those of you out there who work with residents, ask yourself, how many times in your facility does this actually happen? Again, utilize your local acute care hospital. I found they're very eager to develop relationships with you. Even just getting to know who they are can be helpful to both parties. Next slide. Deborah, are you there? Okay.
There. It takes a second.
Okay, very good. Thank you. I won't be so impatient. So for many of you who may know me, I'm not a big fan of acronyms, but here is one that I feel can be quite helpful in ruling out alternative causes for increased mental confusion. These may be things to advise your nurses to look at and consider when confusion manifests or your resident is more confused than usual, instead of jumping to conclusions and deciding it's a UTI or other infection. So this acronym is deliriums, how appropriate for mental confusion. So considering drugs, has the resident been started on any new medication, changes in dosages of medication, or perhaps some kind of new discomfort that they may be feeling. That could be the reason for the confusion. Check out the ears, the eyes, the environment, emotions. Sometimes residents are missing their hearing aids and they just can't see, just can't hear, and possibly even the lack of misplacing their glasses. They feel somewhat disoriented. Also, family members may have come and given them a difficult time, so emotion can play a factor in this as well. The L for low oxygen, consider heart attack or stroke. Infection can be one of those considerations. Retention, when residents are constipated or not able to urinate, that too can possibly cause them to be confused. Ictal state for seizures. That one is, I don't like to use that dehydrated word, so I usually use suboptimally hydrated, but the fact that they are not getting enough fluids or perhaps not getting enough food, that too can be add to confusion. Metabolic can contribute, like in their blood sugars being off, or trauma, head injury, subdural hematoma. So deliriums is something, a good acronym to make available to your nurses as another element for assessing the residents. Next slide. So as you might imagine, I would be saying, as you might imagine I'd be saying, since I work for diagnostic laboratories, laboratory tests have great value in providing a piece of the puzzle for diagnosing infection. But when used in excess, without clinical justification, the lab test can create a dilemma for the doctor and actually complicate the situation. The rationale for ordering labs should be based on finding information that is actionable. If non-specific changes have been identified in your resident, you want to ask yourself, do you really think a UA and CNS will help you decide what's going on? We're sometimes so focused on lab results as the determinant fail to look at or consider how are these specimens being collected. Sometimes if you are not sure that they're being collected appropriately, you end up dealing with a lot of false positive results. And it's kind of easy to detect if you see results with multiple microorganisms. the likelihood is that it's a contaminated specimen, and you want to go check and see how was that specimen collected. Because in order for you to get good, actionable laboratory results, you've got to provide a good, actionable specimen. Another thing that I think we've really gotten on top of this, doing tests for cure. Are your physicians still ordering cultures that they're looking to clear residents of their microorganisms or decolonize them? Diagnostic tests can be positive, as you might imagine, without being clinically significant. We know that residents in long-term care, information is all over in documents stating that many of the residents in long-term care facilities are colonized in the urine with microorganisms. So diagnostic tests which are positive may indicate colonization rather than infection, but they are still driving antibiotic treatments. So this is an area we can really look at and focus on to, to hopefully improve. Next slide. Okay, part of the core elements encourage laboratory support in education on differences in diagnostic tests that are available for detecting various infectious pathogens, such as C. diff. The core elements also advise utilization of an antibiogram, as we're going to discuss in a little bit. But educating your facility nurses on the different tests that are being used. I know a few years ago we used the enzyme immunoassay toxin test, and then we converted to the PCR method for testing for C. diff. And so we started to see more C. diff tests. Did it mean that facilities had more of a problem? Not necessarily. It basically means our tests, in this case, our test was way more specific and more sensitive. Creating a summary report of antibiotic susceptibility patterns from organisms isolated in cultures. This is what you can expect from your laboratory. Next slide. Okay. The role of the lab and the lab testing is to provide the physician with information he or she will use in treating the resident. With this culture and sensitivity, it's to guide the selection of antibiotics if in fact that antibiotic is needed at all. Again, I want to emphasize the lab test alone does not diagnose infection. The lab result must be correlated with the resident's clinical condition. We also have to understand that pyuria, which is part of the UA, is found in over 90% of cases of asymptomatic bacteriuria and 100% in symptomatic urinary tract infection. Therefore, pyuria has poor sensitivity in diagnosis of UTI, where its absence may rule out UTI. Its presence may not distinguish or confirm UTI because it still can be asymptomatic bacteriuria. Next slide. So, as you can see, the facility and the lab should be clinical partners, and they should be working in concert. The lab provides the data, and the facility needs to utilize this data as it works together with their medical team, pharmacist, and infection control committee. Together, they can develop management algorithms, as I mentioned earlier, to distinguish between asymptomatic bacteriuria versus their UTI, viral versus bacterial respiratory infections, bacterial colonization of a wound versus infection, true infection. One of the pearls taken from the Cedars-Sinai Enhanced Care program that I mentioned earlier was their intervention of changing how urine studies were ordered. They started ordering their UA and CNSs as UA, CNS if indicated. and they found less cultures were being done and fewer antibiotics were ordered. Next slide. And further collaborating with your lab partner, work to develop or have them develop a process for alerting your staff when an MDRO is isolated. The earlier your nurses are aware of an MDRO and they assess the resident for clinical signs of infection, the earlier proper precautions can be implemented to avoid transmission of these microorganisms and infections to other residents. As an example, my lab, Diagnostic Laboratories, has included on our CNS report of urines tested an alert to remind nurses and doctors of the possibility that results may not be infection but may reflect colonization. And our medical director, Dr. Patterson at Diagnostic Laboratories, was instrumental in getting this messaging on our reports, because we as a laboratory are committed to supporting your stewardship efforts. Next slide. Next slide is a sample of what we have as our report. And just to show you how effective or how it can be laid out, you can see here on this slide the antibiotics, and the column, 2 columns over from their name is S's and R's, indicating sensitivity or resistant, sensitive or resistant. So to help and support our nurses in nursing homes, because we know how busy they are, we try to flag. And in this instance, you can see this resident, the first organism isolated was an ESBL positive, and it says resistant to all cephalosporins and penicillins. Then the bottom note in the red box is the one that I mentioned that our medical director, Dr. Patterson, added to our reports to give another form of messaging to tell the provider as well as the nurse, look at it and understand that there is a percentage of elderly and long-term care residents that have positive urine cultures and pyuria without clinical evidence of infection. Another way to, bring it more to the forefront. Next slide. So I'm going to talk with you about an antibiogram. You've heard me mention the term several times, so some of you may not know exactly what is meant with this term. The antibiogram is a historical look back of antimicrobial susceptibility of bacteria to a battery of antimicrobial agents. Each facility may have a different pattern or profile of resistance and sensitivity in their buildings. So just because you may be next door to a nursing home, or maybe it's a sister facility, you may not exactly have the exact profile of what is sensitive and what has become resistant. So having your own facility-specific antibiogram is something that you should be asking your laboratory. And I know for those of you who use my lab, we provide this on a quarterly basis to all of our clients. Next slide. So what do we use an antibiogram for? An antibiogram is a really great tool for any clinician when treating an infection empirically. An empiric treatment occurs when they don't know actually what the causative agent is or what susceptibility it has, but it's kind of like a really good educated guess on the part of the physician by the patterns that have been developed in the facility. An antibiogram can also serve as an alternative to a CNS report before these results of the CNS are available. And that's where, that empiric therapy comes in. And even an antibiogram can serve as an alternative to a CNS report if no organism is isolated, but the clinician still has a strong suspicion that there is infection. Next slide. So the next slide is going to show you what the antibiogram looks like. And I'm going to try to just dissect it in a couple of sentences. although that's not usually my style. I usually am very wordy, but this is the antibiogram that we produce. And across the top in the blue is the name of the microorganisms that have been isolated. Along the left are the rows are the antibiotics. Now, where the organism and the antibiotic cross over, that is how sensitive that organism is to that particular antibiotic. And I always say, in a perfect world, which we know we don't live in, that it should say 100 in all of the boxes, because that would mean all the antibiotics are very effective. But as you see, this one, we have numbers that are quite below 100. Now, another significant piece of information that makes the antibiogram useful is you have to have a certain minimum number of isolates. And in acute care, they usually say about 30 is the minimum, but the Agency for Healthcare Research and Quality, in the last bullet on this slide, has said that in nursing homes, that number can be as low as 10. And so the highlighted yellow line is the actual number of isolates. So the higher that number is, which means the more of those organisms that we've been able to isolate from your cultures, it shows then the higher the number is, the more effective the more actionable the information is in that column, in terms of, because you've got some really good numbers to look at. So it sets up a trend. Okay, next slide, please. So an antibiotic with greater % susceptibility will be more likely to get rid of or eradicate the organism than an antibiotic with a lower % susceptibility. So looking at this column with E. coli, you can see that of that particular organism in this building, there were 49 E. coli isolated. So when you drop down and see, you look at ciprofloxacin as an example, because that one is used typically because it addresses gram-positives and gram-negatives, and often it's used in empiric therapy. In this particular building, it's not very effective. It's only 57% sensitive, which means 43% of the time it may not do the job you're intending it to do. So by looking at this column, you would have a better idea of what could be useful in helping your resident and getting better outcomes. Next slide, please. There are limitations, though. This, as useful as the I mentioned an antibiogram is, there are limitations in this tool. There may be concentration differences of antibiotics between the site of infection in the body, in vivo, versus that in the lab, which we call in vitro. The antibiotic penetration to the site of infection may vary as well, so that is another drawback. Some drugs may be inactivated at the site of infection, and there also may be declining levels of antibiotics in vivo versus what we see in the lab, the continuous level in the lab. Data can be skewed due to the small number of isolates, which I mentioned in the previous slide. And the other thing that can skew the data is when you have many repeat data, if it's the same resident over and over again. So that too can skew your percentages. Next slide, please. Okay, so to review what the benefits or what the utilization or implementing an antibiogram, only a physician or his clinical extender, like a nurse practitioner or a physician assistant, can actually decide when and if empiric antibiotic treatment should be implemented. This is not something the nurse decides. Once the decision is made, the antibiogram can provide expected, efficacious information on specific antibiotics. And this can be done by the nurse saying, can I read you, doctor, what the pattern of sensitivity is for this organism in our building, and let him be the deciding factor, of course, him or her. Proper use of an antibiogram may lead to higher levels of empiric efficacy, meaning you get the right drug and it helps to treat the resident to get better faster. You have better outcomes, leading to potential financial savings as well, and avoiding sending the patient out to the hospital. And of course, let's not forget that using an antibiogram is part of the CDC recommendations in their antibiotic stewardship programs. Next, please. So this is a really, when I saw this, I thought this was really exciting. This comes from the Jewish Home for the Aging, the Joyce Eisenberg Kiefer facility. And they were kind enough to give me permission to show this slide, because when they started their stewardship program, their pharmacy consultant and their infection preventionist looked at these metrics here that you see under the antibiotic order characteristics. And what they found was, of 68 antibiotics prescribed, over 45% were ordered by the primary care physician. The on-call physician actually was responsible for over 57% of those orders, which, as you can see, is the majority. Telephone, where the doctor didn't actually see the resident, but ordered the antibiotic over the phone, over 75% of the time that was done. IV antibiotics were 25%. IV antibiotic with no justification provided in the chart or anywhere, that was over 35%. Antibiotics that required dose reduction were 17.65%. This one I was very surprised with. Antibiotic given despite allergy, so 4.4% of the time. That means an antibiotic was given to a resident without taking into consideration their allergies. And 21% of the antibiotics that were started had no documented signs or symptoms anywhere. And this is very significant now at this time, because, as some of you may have already experienced, that surveyors are going to be giving deficiencies for, FTAG 329, unnecessary medications. So, next slide, please. Another wonderful product from the Jewish Home from the Aging. This, their pharmacy consultant put together. This is one of those decision trees that I was talking about for empiric therapy. And the pharmacy consultant developed this in conjunction with our antibiogram. And the person divided it into these 4 categories. And all the different sites also had decisions of empiric therapy as well, but I'm just pointing out the urinary tract. So for simple, uncomplicated UTI, knowing what the likely pathogen is, also something that you get from your antibiogram and your culture results. Their recommendation for initial treatment is cephalexin. The same thing if the UTI is complicated, perhaps just an extended period of time. And then for pyelonephritis, uncomplicated, and the complicated version, they have the Hiptazo that they recommend. And what I really liked is they also coupled it with what the Infectious Disease Society of America, their empiric therapy treatments recommendations. And even so, because they had a number of patients that were treated with antibiotics that they may have had allergies to, they have alternative comments for alternatives for allergies. So next slide. So this is just something that you can consider getting your pharmacy consultant to look at as an option to work something up like this for you. Tracking outcomes from your antibiotic use. Monitor your antibiotic patterns, look at the assessment and documentation of the resident's condition. Also track the appropriateness of the antibiotics chosen. In a previous slide, you saw the metrics one organization used to monitor. As you saw, there was definitely areas in which to improve and do better. At some time, you may want to do a point prevalence study of antibiotic usage in your facility. This is like a snapshot of use at a given time. This can give you a gauge to see if there's a problem or not, and perhaps how extensive the problem is. Outcome measures, you want to really, with all this work that you're doing, make sure you correlate with outcome measures like how many cases of C. diff and MDROs, adverse events, costs, and tracking improvement of susceptibilities on the antibiogram. Next slide, please. Don't forget to share the data. Data is most useful and powerful when shared. Give feedback to your providers so they can see their practices and possibly even how they compare to other providers in your facility. I think physicians, I don't know if nurses are pretty competitive, but doctors may be as well. So when there's comparisons, and it can be done anonymously, I've seen that done, where you assign them a color or a letter, and if they come in, you know, at a point where it doesn't reflect good practice, they may just by that try to improve. Don't forget to share the information with your staff as well. And really give yourself credit for what you're doing. Make sure that you document what your program is doing. To sustain change, show clinicians and staff the impact of their stewardship efforts. Next slide. So you may be asking yourself, what's in it for me? What's in it for the facility? So as we get ready to conclude, we're going to summarize some of the benefits that for long-term care facilities. Improved resident safety, and by that you will find resident family satisfaction. Your staff will benefit with more involvement and more awareness of antibiotic use and better infection control, prevention and control practices. You'll have potential for improved survey compliance with regulations related to quality of care and infection control, and even more. Improved relations with your referring hospitals, and lastly, decreased costs. Last slide, next slide, 2 more to go. So in summary, microorganisms continue to mutate and develop resistance as we speak. Overutilization and inappropriate use of lab and radiology testing may contribute to increased use of antibiotics and increases in multi-drug resistant organisms. Work with your lab partners to receive and understand reports such as your antibiograms. Use those 7 core elements for stewardship when developing your program. Establish meaningful metrics for monitoring your laboratory testing and antibiotic use specific to your facility. We always need to go back to this very basic idea. Maintaining practices in infection prevention and control protocols can prevent transmission of infections. Using your antibiotics judiciously so we have them available when we really need them can decrease antimicrobial resistance while avoiding adverse reactions and at the same time decreasing costs. And finally, education is a crucial element and a thread that is woven through all infection control and antibiotic stewardship practices. Education extends beyond your staff and should always include residents, their families, and your providers as well. And with that, I think we are, I'm finished, and I don't know if we have time for questions. Or
I've just got a couple.
Okay.
So we just have a couple minutes.
Epson also had another, just a reminder for future. Dr. Epson, are you there?
Yes, I'm here.
Okay.
So how do you get a hesitant medical director involved?
How do you get a hesitant medical director? Dr. Epson, do you want to answer or you want me to answer?
Go ahead, Dolly.
Go ahead. Well, when the head guy, when the medical director is difficult, it's more challenging. But I can tell you that what some facilities have started to do is reach out to ID physicians, infectious disease doctors, who have expertise in antibiotic stewardship, and get them to explain that, number one, this is no longer an option. This is, January the 1st here in California, we are mandated to have this stewardship program up and running. CMS has this on the books for the rest of the country next year by November the 1st, but we already are right up against the fence. So he can be resistant, but he still has to comply, because in the end, who gets the brunt of it if you aren't complying is, you, because the surveyors don't regulate physicians. But beyond survey, in the best interest of our residents, which is really what we're talking about, this is, what we need to be keeping in mind. So resistant, you've got to bring him materials, use resources. You have good people in our California Department of Public Health and local public health departments. We have some awesome people. You can ask to get some help from them to come in and meet with the doctors.
Great, thank you. I want to be respectful of everyone's time. We did say this was only going to be 60 minutes. So if you still have a question, drop me an email and I can forward it to Dr. Epson or Dolly Green. I'm going to turn it back over to you, Dr. Epson, for final words.
Yeah, we'll work together to develop responses to any remaining questions. Well, thank you. Thank you so much, Dolly. That was excellent. I just wanted to show this last slide with our schedule for this webinar series, and we're pleased that we have confirmed our date and some excellent presenters for our next session, which is going to be on November 30th at 1 p.m. And this is going to focus on strategies and approaches for tracking antimicrobial use as well as outcomes in nursing homes. So please join us then. You can register at the QCHF website, and I've shown the web URL address at the bottom of this slide.
Great, thank you. Thanks everyone for joining us today. You'll receive an evaluation via email tomorrow sometime. Please complete and return if you need one BRNCE. And again, as Dr. Epson said, hope you can join us on November 30th for our 5th in the series on the antimicrobial stewardship in long-term care. Thanks everyone, good afternoon. Thanks Dr. Epson, thanks Dolly.
Thank you.
Bye. Bye. Thank you.